Okay, good evening, everyone. Thank you for your patience while we prepared. Welcome to the My Horse University and the Extension Horse Quest live webcast titled Lameness and the Performance Horse. This webcast continues our horse health series, which will include 2 more webcasts on important health topics. Our presenter tonight is Dr. Ann Rashmir, Associate Professor at Michigan State University's College of Veterinary Medicine. Dr. Rashmir earned her DVM from the University of California, Davis, and is a diplomat of the American College of Veterinary Surgeons. She was an assistant professor in veterinary molecular biology at Montana State University for 3 years, and then worked for 15 years as an associate professor of equine surgery and medicine at Mississippi State University. She joined the Michigan State University's College of Veterinary Medicine in 2009, where she studies equine skin diseases and also has an interest in orthopedics. Please note that you are able to ask questions during the presentation using the text chat to the left-hand side of your screen. Our questions will be facilitated by Norelle Stubbs, a visiting research associate at MSU's College of Veterinary Medicine. She is a physiotherapist and will receive her PhD at the University of Queensland in Australia. Our presentation is going to be recorded and uploaded to our website if you want to review it at a later date. And at this time, I'll turn the presentation over so we can get started.
Thank you, Amanda, and thank you all for coming. I did want to talk to you about lameness for a couple of reasons. One is it is the #1 cause of economic loss, according to the National Animal Health Monitoring System study. As you can see as you go down here, that 9 to 14 events occur per 100 horses, with about $432 per event occurring. It's got a small case fatality rate relatively, but here's where we can really make an impact on lameness, with this 110 days lost per event. So a lameness in a horse generally averages 110 days lost to performance. As a comparison, you can see colic is less common with 4 events per 100 horses and less expensive, frequently 1 dose of Banamine sort of cure at about $160 per event, but much higher case fatality rate. Now here's another big difference too, is that there are only 2.4 days lost per event. So if a horse colics, there's not a whole lot in the way of losses, as long as the horse recovers, not a whole lot in the way of losses in training or performance. But certainly if the horse is lame, it does cost quite considerably in time out of the sport. So this is the plan for this afternoon's lecture. First, we're going to cover a little bit about prevention of lameness, including conditioning. And there's a very large component to conditioning. Now, we don't have time to cover that today, but I do want to make a few comments about it. Nutrition, again, very large component to performance nutrition. And there is an entire My Horse University subject area on nutrition, which I would encourage you to see. Shoeing is critical as well, and saddle fit and shoeing are 2 things I'm going to cover a little bit more extensively. And then for the bulk of the lecture, we're going to talk about lameness evaluation, including nerve blocks and joint blocks, radiographs or x-rays, ultrasound, bone scan, MRI, a little bit of gait analysis because we happen to have a very good system here at Michigan State University with Dr. Hillary Clayton, and a little bit about thermography, mostly with saddle fit and thermography, but it is used also for the diagnosis of lameness. And then for treatment choices, really like to kind of focus a little bit on what's new, things you may or may not have heard of. That would include IRAP, stem cells, platelet-rich plasma, Tildren, which is not available in this country, but your veterinarian can get it actually legally. And then I do want to emphasize the importance of rehabilitation and physical therapy, and Norelle will be speaking about that for an entire hour in about a week. So I'm not going to dwell on that at all. I did want to cover a few things about some of the oldies but goodies, the drugs that you commonly are using right now, the bute, Banamine, Ketaphin, Cosequin, Adequan, hyaluronic acid, and maybe a little bit about shockwave if we have time. So first, as far as prevention of lameness, certainly picking your horse carefully will go a long ways towards getting a horse that performs for you for a good length of time and performs well for you. I highly recommend a pre-purchase exam on any horse you're going to purchase. And the horse should actually have some of the very standard things that we think about for a good horse: good conformation, a personality and ability suited for its intended use. You know, the horse that has to spend an hour in the loping pen before you can cut on it is not a horse that's going to actually hold up to use as long as a horse that you can lope for about 15 minutes or 10 minutes to warm up. I also would recommend at the pre-purchase examination banking blood. What this does is it you would actually have your veterinarian take blood from the horse and actually separate it out and freeze the important components for evaluation of drugs. And so if the horse were to turn up lame days to weeks, and sometimes even a month or so later, you can actually go back and run that blood, have it analyzed to see if the horse was drugged at the time of pre-purchase. And I do encourage that in all pre-purchase examinations. Conditioning is a critical part of prevention of lameness. We aren't going to spend a whole lot of time speaking about it. I know Norella is going to speak about it some more as well, but it is critical. As is the riding surface. Certainly, horses that actually have access to better riding surfaces do last longer and do perform better. Riding surfaces that can be manipulated with either tractors or whatever, certainly to keep them comfortable for the horse, definitely encourage you to do that because it will make a difference in the long term for your horse and frequently also in the short term. The amount and type of riding and riding schedule is important as well as far as conditioning goes, but also we know that there are some things that are more problematic for the horse in the long run. The horses that get ridden every day or regularly certainly do better than the horses that tend to be sort of weekend warriors, where it would go out and be ridden quite extensively on the weekends and then put in the stall and rested the rest of the time. I do want to kind of mention something here with this forget the one last time. There are quite a few in my career of looking at lame horses, 20-something years of it, where I've had clients come to me and say, you know, the horse was doing really well, and I knew the horse was tired and I was tired, and the trainer asked for just one more time. And that would be either one more time around the jumps, one more time around the barrels, one more cow to cut, or steer to cut, whatever. And that was the time that the horse actually really had more than it could take, and that's where the lameness frequently originated. It is something to keep in mind when both you and the horse are fatigued. It's a good time to quit and not go just that one extra moment where you're more likely to get hurt, and that's true of any athlete in any sport. And remember that you're in control. It's your horse's destiny that you're in control of, and if your trainer wants you to do one more, but you know that the horse is already beat, I would encourage you to actually stand up for your horse. Nutrition, moving along, is critical to the horse's performance, and certainly we know that feeding oats and grass hay is certainly not something that a horse can long-term perform on anyway. There is a whole, as we said, a whole area for nutrition in My Horse University. I would encourage you to look at that. And then Farriery is the next thing we're going to actually jump into and have a look at first, because it is critical to the performance of your horse. So I got these photos and this demonstration from Dr. Tia Nelson. She's a veterinarian and a farrier, and one of my favorite farriers in the world, actually. And I think she does a very nice job of showing with these photos exactly what needs to be done on these horses that typically, performance horses typically, because partly the way they're housed, tend to grow this long toe and a low heel. We need to actually get a farrier that is consistently able to address this problem, because it is such a common problem in performance horses. So just to show you this long toe and low heel, and then as you can see here, she's got it marked where the toe needs to come off from not just the bottom to shorten the toe, because that will actually get into soft tissues and sensitive tissues if you just try and take from the bottom. It also has to come off from this dorsal surface of the hoof. And you can see this horse, same horse as here, with the hoof properly prepared. I'm going to show you the same horse and the same hoof from the underside of the horse's foot. So here is the overgrown foot. You can see the heels are quite a bit of distance right here from where the angle of the hoof is. What we're going to do is actually move that back so the horse's center of balance is moved back as well. So we actually start our cuts right here. Okay, and what that will do is actually give us a much wider surface area for the horse to stand on and move his center of balance back in his foot, which makes a lot more comfortable for his tendons and his navicular bone, and actually the rest of his joints going up the leg as well. So this is a very nicely prepared foot compared to what it was. So what do you think about this horse's feet? This is a horse that had a long toe and a low heel, and so the horse has now got elevation to his heel. Is that actually addressing the problem? And I think you can see, just even from the shape of the horse's foot and the lines that are growing down, this is a horse whose feet are very uncomfortable, and its hoof is growing oddly in response to that abnormal force on it. So what's better to do in these guys is, instead of having this kind of propped up sort of toe, opposite of a high heel actually, a toe heel, What we're going to do is we're going to actually change this so the horse actually has a better weight-bearing surface and he's a lot more comfortable and his foot will actually grow better in response to the better shoeing and better trimming. So here he is standing up and here he is with the original shoe on. I think you can see his foot is way far in front of his heels now. And that's bad for his center balance, which should be back here. Also, his heel of the shoe is actually pinching in on his frog, which is very uncomfortable for horses. And the frog with the shoe by the frog is actually too tight. It's not allowing for heel expansion. And so here is the same horse with the shoe off. Here's the areas where we're going to actually start our cutting. Here's where we want to move the center balance back to. And this is the end result. So you can actually see now that this little area here, in the horse that's got a not too well prepared foot, is not nearly as large as this area in the well prepared foot. Plus, the toe is way far forward on this horse, so the center of balance is actually way far forward. And this is much more central on this horse's, now that this horse's foot is properly prepared, it's much more central, and this horse is actually going to stand much more comfortably. The shoe goes back on, and I can see the heels are much wider. The surface that the horse is actually going to walk on now and share the load of his weight on is much larger, so the force per square inch is quite a bit different now and much improved. And then the webs of the heels are far enough apart that you're not pinching on the frog. I hear that nobody can see my arrow, so I apologize for that. Let me go back and just do that one horse one last time. As you can see, the heels here are pinching in on the frog. Can you guys see the arrow? Hope so, anyway.
No.
No, okay.
You may try maybe closing out your sidebar.
Okay.
See if that has something to do with it. And then,
can you see it now?
and you need to, nope, click on your arrow again.
I did. Can you see it?
Nope, I sure can't.
How about if I use this, then the whitebird overlay? Maybe I'll use this. You guys can see that, right?
Yes, I can see you drawing.
Okay, good.
Yep.
Okay, well, we'll try this then. I'm sorry, I apologize. Okay, so just to show you that this is a much smaller surface area here now. You can see that, right? Yes, okay. I'm sorry. Much smaller surface area in this area as well. This is just with the shoe off. And much wider surface area now that you got the shoe appropriately prepared. And then again, the heels here, the shoe does not impinge on the frog at all. And the heels are wide enough to allow for heel expansion. Heels of the shoe are wide enough to allow for heel expansion of the horse's foot. Okay, so here's the horse that's now uncomfortable and standing up on its toe, with the lines on his hoof. And here's the horse actually after that first set of shoes was put on. Again, much more upright, just overall, the toe much shorter, horse is much more comfortable. And then I see here also, can everybody hear me? Because I actually see that somebody has indicated they cannot hear. Okay, good. Looks like some people can hear anyway. And then here's the same horse after the shoe. Now he's grown out about 6 to 8 weeks. And you can see his toe again is trying to get long right in here. And so this is a horse, again, that needs to be consistently trimmed appropriately to keep his heel balance and his toe balance and his center of gravity in appropriate position. So here he is again after a second shoeing. And again, a much more normal hoof pastern axis and much more comfortable horse. And this is that same horse looking from the backside. I think you can see here very nicely the heel support of the shoes. We can actually look from the horse's, the back of the horse's foot and actually see the heel support, and that's the way it should look. Now, I do have clients that tell me that their horse will pull the shoes off, and that is the case in some instances. I generally have those horses wear bell boots full time. The gum boots work very well. It can actually come down and cover the heels. We do ask you to look at underneath those bell boots every day to make sure that they're not rubbing the horse, but again, consistently they can be worn to protect the heels when needed for horses that have the big strides. Okay, so that concludes the little bit of lameness, shoeing as it pertains to lameness that I wanted to address today. And I want to move along to some lameness with thermography. And thermography is actually looking at the heat that comes out of the horse's body, or your body, with a thermal camera. It's a very specialized camera. It's the same sort of camera that they use when they're trying to determine if somebody gets off the airplane with SARS or another infectious disease and has a fever. And so it's a very sensitive camera when we use it for horses to determine lameness. It also can be utilized to determine problems with saddle fit. And that's what we're going to mainly concentrate on today. But it is a non-invasive tool, and again, it is body surface temperature driven. If you're going to use it in part of the lameness examination, you should generally get a thermographic image prior to starting the moving part of the lameness examination. And what you're going to compare is right leg to left leg, both front and hind, and left side to right side of the horse. The signals should be symmetric. Any change of heat seen with the thermography is generally the result of changes in blood flow, and the baseline you took before you trotted the horse is then used to compare a later examination of the horse. And I think you can see here, this white is a hot area on the horse. This is a horse that's got some tendon issues. And you can see this is the upper part of the limb, fetlock, and then also the foot of the horse. As far as saddle fit goes, and I said we're going to use some thermography to look at that because I think it really nicely illustrates the problems that can occur. The saddle can be having a problem, or the saddle fit can be abnormal because the saddle itself is asymmetrical. It can be a problem because the rider is asymmetrical, or a problem because the horse is asymmetrical. The problem is that most commonly the only thing we can fix well is the saddle, and so that's what we generally concentrate on, or sometimes we can fix the rider as well. So let's look at this. This is a thermographic signal with one of the floor cameras, and this is courtesy of Dr. Jim Waldsmith, who does quite a bit with thermography and teaches many of the thermography courses. And I think you can see here, this is the scale for temperature. The purples and blues are cooler, and as you get up into red and white, it gets to be much hotter. And this is an English saddle. I think you can see here, this is the back of the saddle, flaps, etc. And so here you see a fairly red area right here, and that's a sign that that has actually created more heat than the rest of the saddle because it's due to friction with the saddle and the horse. And I think you can see this is the horse. Here are the horse's ears up here, the neck, the mane. Here's the person holding the horse here. You can see she's in a V-neck blouse right here. And this is the horse's withers, and this is you're looking at the horse's hips. And I think you can see this horse is actually asymmetrical. Here's the line. This side is bigger than this side, and that corresponds to the heat seen right here on the saddle. It's not that surprising that the horse is asymmetrical. Your right hand, if you're right-handed, is probably bigger than your left hand. And we do see this sometimes in horses as well, that they will be bigger on one side than the other. And so this again would be something where if you could adjust that saddle, it might make this horse's withers more comfortable. In fact, this horse was presented for soreness at the withers, and it's no surprise since there's more friction here with that saddle, not quite fitting as well on the right side as the left side. Here's a Western saddle, similar thing. I think you can see here this horse might be a little asymmetric as well, but certainly here's the back side of that Western saddle. Certainly can see here quite a bit of red in this area, and again, meaning that it is hotter in that area. You actually see that a little bit of red also on the horse. Again, this is a saddle that could use some alterations to make it more comfortable for the horse. So let's move along to our traditional lameness examination. We do start at the horse's head and look for symmetry. We do palpate all the way down the horse's cervical spine. It's sometimes difficult to tell if the horse is actually lame or if the horse is neurologic, and so one of the things that can give us a clue would be palpation of the spine. Also, it'll give us a clue as to whether the horse's neck is painful. Certainly horses can be lame from neck pain. Just like you, if you've ever had a stiff neck and you've been trying to drive your car, you don't move your whole body, or you don't move your neck to turn to look to the right or left. You actually move your whole body generally. So horses can actually have a hard time turning, which is perceived obviously as a lameness because of neck pain. So do take a good feel of that area. Again, looking at the scapula, humerus, radius and ulna, down to the carpus or knee, fetlock, pastern, and coffin joint and foot. We do palpate all this all the way back, the horse's back, all the way down the horse's hind limb as well, palpating the pelvis, the femur, tibia and fibula, the hock or tarsus, fetlock, foot, etc. Now, We're generally looking for symmetry. We're definitely looking for heat or pain. We're also palpating all the muscles, ligaments, tendons, and joints along the way. We are, in addition, looking for some compensatory problems. We know that horses, for example, can have sore backs from having sore front feet, and that's actually a fairly common reason why horses do get sore backs is because their front feet are sore or their hocks are sore. They can also have primary problems with their back, such as a saddle fit in the withers area can make the withers directly sore, or overriding vertebra, the withers make them sore. And then Norelle's going to talk a little bit, I think, about backs. She's got a very nice study now looking at some diseases that are primary to the thoracolumbar spine. So sometimes the lameness will be very subtle in the feet, but yet we can feel some back pain. We need to kind of tease that apart. Maybe it is the feet, maybe it is the back, and maybe it's a combination of both things. But in the general lameness examination with the palpation, it's something that we actually want to start getting clues on. And every bit of the lameness examination will be recorded. So continuing with the standing part of the lameness examination, we look to the hoof testers. These are very nice hoof testers. All hoof testers are not created equal. These are GE hoof testers. You can actually have very good leverage on them and get a very nice squeeze on the foot. We do a comprehensive examination of the foot, starting at the heels and working all the way around the sole of the foot. If the horse is acutely lame after shoeing, with the next day or two after shoeing, we do tap the nails on the foot, looking for perhaps a nail that's too close to that white line or sensitive lamina. I think you can see on this horse also, long toe, low heel, and what has he got here, the little bit of redness, he's actually bleeding down the front of his foot or his lamina. So hoof testers are a key aspect of the lameness examination, in part because most lameness does occur in the front feet of the horse. 80% of the lameness that's estimated do occur in the front feet of the horse. So if you ever want to look smart and just guess the front feet, because more than likely you'll be correct. Now, sometimes these feet will be very, very sore. Let's say a sole abscess, foot pain can be soft tissues of the foot, can be the navicular bone, can be the coffin bone, can be anything. Sometimes it'll be very, very sore. And then sometimes you kind of wonder, particularly at a pre-purchase examination, if there's no sensation, because you can actually squeeze these pretty tightly. If there's no sensation, I generally worry that the horse has already had a neurectomy, say for navicular disease, and at that point I look at those horses very, very carefully. So they should have some sensation, but should not be painful to hoof tester examination. As far as the forelimb lameness, we are going to show a video here in a second, but I do want to make a few comments. We do look at both forelimb and hind limb lamenesses, both in a straight line from the front of the horse and from the back of the horse, and also in circles. And I would encourage you to look both from straight lines and in circles when you're looking at your own horses for lameness. The traditional thing we look at for the forelimb lamenesses would be the head bob. Down on the sound, basically. The weight of the head and the neck and shoulder area is carried on the most comfortable leg. So to give you an example of what this would be for you, if you were trying to carry, say, a tool chest and your right wrist hurts you and your right ankle hurts you, you'd probably carry your tool chest in your left hand, taking the weight off the most uncomfortable area, like your right ankle or even your right hand. If the horse is bilaterally lame, so that means lame in both front or both hind legs, you will have to watch the horse in a circle to better assess the lameness. Generally, the inside leg is under greater stress and under greater weight, and generally it's the inside leg that you will see that will be lamer, the inside leg on the circle that would be lamer. So the right leg on a right circle or the left leg on a left circle. Now occasionally, you'll see the outside leg be the more lame leg, in which case we generally assume that the inside part of that outside leg is the source of the pain. And so if Amanda, you could play that video, I'd appreciate it. We're going to watch this horse a couple times. And this horse is lame. I think you can see right here. I think you can see right here as the horse goes down, his head, the whole way his head is going down. It's down, 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 down. We watch this again in slow motion. And I think in slow motion, if you're watching very carefully, you can actually watch the whole horse's body sink into that sound leg. So down, 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 down on the right front leg, down, down, down. Again, I think you can see the whole horse's body, most noticeably the head, down, down. Come back this way again. down, 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 down. Hips not moving very much at all, very symmetrical behind, so we know that's a forelimb lameness. Again, the hips not moving, head is moving, down on the right front, lame on the left front. So let's go to hind limb lamenesses now. Hind limb lamenesses, again, evaluated in a straight line and in circles. I've just shown you in the straight line because I think we can actually see these lamenesses. I have chosen lamenesses that I believe are fairly severe. Now, certainly the performance horse lamenesses are going to be much less severe, but much harder to see. And so we're going to continue to look in the straight line. And you can, I think it helps because you can line the horse's head up against that wall and might actually help you see the head bob. The same thing is true of the hip hike. The hip hike is commonly used in the evaluation of the hind limb lameness. The hip is elevated when the lame leg is on the ground. Same thing as for the head, the weight of the head and the neck and the shoulder. When the lameness is in the front, the hip is elevated when the lame leg is on the ground. So the weight of the hip is off the lame leg. The head bob can also be used for hind limb lamenesses, but the head will be down or forward when the lame leg is on the ground. So down on the sound only applies to the front leg, not the hind leg. And so next we're going to watch the hind limb lameness video. Again, we'll watch this horse in a straight line from front. I think you see the whole horse's rear end moving up, 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 up. And once you start looking at that, you can also notice that his leg swings in quite a bit. Here he is from the side, up, up, up. His head is fairly flat and level, but his rear end is moving quite a bit. So we know this is a hind limb lameness. Up, up, up,
okay.
Up. In slow motion, you can see it even better. Up, 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 up. You see the leg swinging in as well. That's to avoid flexion of the limb. Swing in, hip up, swing in, hip up, swing in, hip up, swing in, hip up. I think this very nicely demonstrates a left hind limb lameness in this horse. These videos are courtesy of Dr. Bob Linford, who worked together with, he and I worked together at Mississippi State for about 15 years. Up, 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 up. Again, the whole horse's rear end is lifting up, and that left hind leg is hitting the ground. I think you can also hear the sound of the horse hitting much harder, harder, and that's another clue to which leg is lame. So I did want to mention that subtle lamenesses, which can affect performance, are frequently better seen with the horse under saddle. And so subtle lamenesses and frequently hind limb lamenesses as well are better seen with the horse under saddle. So after we watch the horse trot, both in circles and straight line, we do then perform flexion testing on the horse. So the horse has been trotted for a baseline lameness. We flex up each individual joint, and then we trot the horse back off and compare the original lameness to what we've seen after the flexion test. Originally, in part of the lameness examination when we're palpating, we have actually already picked up the limbs and flexed them as well when we're hoof testing, actually before hoof testing frequently, but now we're actually going to hold the limb in flexion. And this is a flexion test of a fetlock. Generally hold this for 30 seconds and trot the horse off. This would be a hind limb fetlock flexion test. This is a little bit misleading because it actually flexes up the hock and the stifle and the hip as well, just the way the horse's stay apparatus is, that we flex everything up together in the hind leg. The stay apparatus is what lets the horse sleep standing up. It locks everything together, and so you have a very difficult time isolating these areas from one another. But anyway, fetlock flexion in front, carpal flexion in front, we generally hold this for 1.5 minutes. Fetlock behind, generally another 30 seconds, and then this is what we call a traditional spavin testing, which is flexion of the fetlock, hock, and stifle, and hip as well. And so horses that have lameness in any of these areas will be painful in each of these areas upon flexion testing. I do want to say a word about the specifics of it though. Again, this spavin testing is going to actually stress most of the joints in the hind limb. The fetlock testing in the front limb can actually be very positive, not just from fetlock disease, but also in the horses that have navicular disease. It does actually create some stress back in the navicular bone because of where the tendons lay in respect to the navicular bone. So it will help you get an idea of where the horse is lame, perhaps, but it may not tell you the whole story. So for the whole story, we really need to move along to nerve blocks and joint blocks. This is very similar to when you go to the dentist and say you've either got a cavity that needs to be filled, perhaps would be the best explanation, and the dentist injects a little Novocaine in there. Your area that he's injected into becomes numb and takes away the pain or the painful sensation of drilling then. And so that's exactly what we're doing for horses. We're actually numbing the areas of the foot first and then moving up the leg to the point where we see the horse is now sound. So the injection is made low down first, blocking the nerves to the caudal part of the foot. The anesthetic agent is allowed to work, generally from 10 to 15 minutes, and then the horse is trotted off again. And if the horse is sound, we know that that is the area that's causing the lameness. And so we then focus on that area for our diagnostic, radiographs, ultrasound, etc., MRI. So if that does not make the horse sound, we move up the leg until we get to the part that's blocked, and the horse is now sound. So we know if it blocks at the fetlock, that's the source of the lameness. If it blocks at the carpus, we know that's the source of the lameness. Okay, so you basically move up the leg until you get the sound area once nerve block has taken effect. Sorry, until you get a sound horse. Sorry, let me say that again. You start your nerve blocks down low, and you see if the horse is sound after that nerve block works. And then if that doesn't work, then we move up to the next area. If the horse is not sound, then we move on up the leg until we get to the part where the horse is now sound. And we know when the horse becomes sound that that is the area that is the source of the lameness. If you don't do nerve blocks or joint blocks on the horse, you may actually not have the correct area for lameness. We do see that quite often, actually, that people present thinking the horse is lame in one area and it's actually lame in a different area. But the nerve blocks generally are the first line of defense in actually telling where the horse is lame. Again, we certainly can't ask them like our doctors might ask us, where does it hurt? And this is our way of basically asking them where it hurts. Okay, we're going to go ahead and move along a little bit to gait analysis, which can be actually an adjunctive therapy or diagnostic for lameness examination. And this comes from Dr. Hillary Clayton, who is one of the preeminent gait analysis individuals in the country, and she does actually have she's one of the preeminent gait analysis individuals in the world, actually, and she does have the state-of-the-art equipment, actually, currently with 10 cameras and 6 embedded force plates. But to give you the idea, this is a horse actually standing on a force plate. Now we normally bury those so the horse can't see them, so it doesn't alter the horse's stride. But you can actually see the horse standing on a force plate here, and that is actually hooked up to this computer, and you actually can see on the computer how much force the horse is putting on the plate. In addition, the horse has actually got markers on it, and the cameras are actually then able to determine the position of different parts of the horse's body with respect to its movement. So this is a horse then that's actually now, I believe, doing canter pirouette on force plates. So here we are with Piaffe on the force plate, and then we're going to show you what that looks like on the gait analysis. So if we could prepare that video as well. The force plates are in here. You cannot see them. The cameras are here, and they're actually filming the horse. And so here we go. You can actually see the force of the horse that strikes. These lines actually indicate what force the horse strikes with. And the cameras have picked up the outline of the horse. I wonder if we could play that back one more time. So here we go, the horse is moving, there's the force. Again, the cameras are picking up these reflectors that have been placed on the horse, and you actually see the movement of the horse's limbs. So you know which limb is actually striking with which force. Now, most lamenesses that we're going to see won't necessarily need this gait analysis, but for very subtle lamenesses, it can actually be something that'd be very of great interest. So it may be the most useful in distinguishing between the subtly lame horse and the subtly neurologic horse. So if you actually put one foot on each of 4 different force plates, you can measure with the force with the horse is standing and maybe even moving, and it maybe make the determination better if the horse is actually slightly neurologic or if the horse is slightly lame. Currently, the treatment for the slightly neurologic horse is actually give them a little dose, actually not a little dose, give them the full dose of Marquis and see if the horse responds. And certainly this would be something that would be better diagnosed by gait analysis than by simply trying to treat the horse and seeing the response, or potentially anyway. Once we isolate the area of lameness, we're generally ready for radiographs, or also known as x-rays, and it is the first choice for imaging bone in the horse. It is the least expensive of the alternatives for imaging bone. And I've given you some examples here of this is the tarsus or hock of the horse. And this is a normal hock of the horse here. And these areas right here are the ones we frequently concentrate on because these are the most important areas for lameness in the performance horse. And this is a very normal tarsal metatarsal joint, and this is the distal intertarsal joint. And I think you can see on this horse, he's got quite a big lip right here. Okay, this is a very abnormal tarsal metatarsal joint, or the distal joint in the hock. And here's the distal intertarsal joint right here, which is actually fused in this horse. And then when you look at the x-rays, you can see here's that big spike at the tarsal metatarsal joint. Did I say that wrong? Sorry, tarsal metatarsal joint here. And here's the distal intertarsal joint right here as well that has disease and actually is starting to fuse. So digital radiographs are better. I guess we're having problems with the pointer again. I apologize. It may be every time I go to the video, it cuts off my pointer. See if I can get it back here. I'm sorry. So anyway, here's that distal intertarsal joint, tarsal metatarsal joint here. I hope you can see the pointer now, you guys. Can you see that? And here's the fused joint here, or partially fusing joint here. Okay, good. Thank you. And then here's that big lip on this horse here, which you can actually see here as well in the radiograph. So there's the abnormal distal, that's an abnormal distal intertarsal joint right here. And here's the abnormal tarsal metatarsal joint. And again, radiographs are a fairly inexpensive way of looking at this. The problem with radiographs is they actually need quite a bit of bone change to occur. About 30% difference from normal needs to have occurred before you actually see a change on the radiograph. And so certainly MRI has much better contrast and much better to see early changes in the bone. Digital radiographs are actually quite a bit better than standard radiographs, and I think many of the performance horse veterinarians have actually gone to digital, which actually helps them quite a bit. Okay, so let's talk about diagnostic ultrasound. For the horses where we suspect a soft tissue lesion, and some actually bony lesions as well, but mostly soft tissue lesions, ultrasound is going to be our best bet. It is the first choice for imaging soft tissues. And you may know of ultrasound from your horse, but you also may know of it from somebody that you know that's had a child. It is commonly used to image the fetus in human pregnancies. Ultrasounds are classical sound waves that you cannot hear. They're a different pitch than we can hear, and the sound waves travel differently in the different tissues. And so what I've done here is I've actually shown you a very abnormal suspensory ligament in this horse. I'm going to show you where that is. So this is a superficial digital flexor tendon, deep digital flexor tendon, and suspensory ligament right here. Okay, and so if we look at it this way, okay, with a transducer or the probe for the ultrasound, we're looking at the tendons this way. So superficial, digital, and suspensory ligament right here. If we're actually going to make a slice this way and look at it, and you can do that with the ultrasound probe by just turning the head in the transverse direction. So there's the superficial on the outside, here's the deep, and there's the suspensory ligament. And I think you can see this very large hole in the center of the suspensory ligament is quite abnormal. It's markedly enlarged. The whole ligament is very enlarged, and it's got what we call a hypoechoic core lesion, which is a big core lesion right here, and it's a black area, which is making it, which is the term what hypoechoic means. So this horse has got a very large suspensory ligament lesion, or suspensory desmitis. So we're going to talk a little bit more about ultrasound when we talk about bowed tendons. And here we're talking about the superficial digital flexor tendon, which is the most superficial, and this is it outlined here, which looks fairly normal here. I think you can see now that you're starting to see some holes in here, and this is a horse that's got tendonitis, or a bowed superficial digital flexor tendon. And then here, this black area again, the hypoechogenic area, is fairly large, and this is a very large lesion in this superficial digital flexor tendon. And again, that's a bowed tendon, and best picks up with ultrasound. So here's what you're really looking at, or partly what you're looking at here. Here's that large lesion in the superficial digital flexor tendon. And here you can see this is a tendon in cross-section, and this is the area where the horse actually bled into the tendon. This is actually a fairly early lesion. And so what you're seeing is that sort of change here in your ultrasound. The other thing that ultrasound is extremely good for is seeing when it's time to send that horse back to work. We know that when this area has still got a hole in it, those tendon fibers are not healed, and that horse going back to work would only result in bowing the tendon or having additional problems with the tendonitis and potentially becoming a chronic problem for that horse. And so we definitely love to have the ultrasound looking extremely good by the time that the horse goes back to work. Now, having said that, horses with tendonitis, and that could be the superficial digital flexor tendon, deep digital flexor tendon, and certainly the check ligament and the suspensory ligament, all of those structures actually, each one of those diseases, the horse needs to be in some amount of work shortly after it gets injured. And what that does is it lets that fiber pattern align appropriately. And so horses that get walked religiously after having an injury to one of the tendons or the suspensory ligament or the check ligament, the horses that start walking and actually go up from there to exercise slightly with somebody having the horse in hand, those horses do much better because the fiber alignment is better, the healing is better, and the long-term use of that horse is maintained. We do follow that with the ultrasound, so once the lesion starts filling in, the exercise gets increased gradually so that as the horse can tolerate it, as the tendon can tolerate it, the horse's exercise gradually increases and increases to the point where we can actually get on the horse start riding. Again, we do bring the horse back periodically for rechecks to make sure we're not overdoing it with the exercise. Excuse me. I did want to point out some contributing factors that we probably need to consider when we have a horse with tendonitis or bowed tendon. We've already talked about improper shoeing, and that is a significant factor. Uniform training regimen is something that we probably ought to take a minute to address. Horses that do the exact same thing every day are actually at more risk for having a bowed tendon or getting tendonitis. We should generally vary the horse's activity. So if one day you take the horse and say you're working a dressage horse, certainly at some point or another, not doing all the moves or doing different moves on different days would help that horse. And a day off where you actually do something besides dressage would even be better for that horse if you possibly can. So anyway, changing the regimen up is good. In a horse that gallops a lot, you might trot more on certain given days of the week. And again, the training regimen of the horse is so important that it really ought to be a whole presentation in and of itself. We certainly know that fitness is a problem. Horses that actually have been put in stalls for quite a period of time because they've hurt some other area, or even babies that are in the stall because their mother is sick, or they've gotten some respiratory infection and have to be stalled up, or even a colic. Those horses that have been have had prolonged layups certainly need to gently address their going back to their level of training. We do see horses that get turned out for the first time in a long time. They go out, buck, kick, and play and come back with a bowed tendon. So we do want those horses that are really out of shape to actually get some level of fitness even before they're turned out. Lack of adequate warm-up can be a problem in these guys as well. And then I do want, because you can see here that I put it in different colors, pre-existing unresolved lamenesses can be a significant problem for horses with tendon trouble, or for horses that can cause tendon trouble. So what happens is the horse is actually lame for some other reason, maybe never even recognized by the owner, or maybe just subtly off. The horse is actually used fairly hard, and what has happened is the lame leg is actually putting more or causing the horse to put more weight on the good leg, and frequently it's the good leg that goes on to then have tendonitis or have a bowed tendon, develop the bowed tendon, because it's overstressed due to lameness on the opposite limb. Can also be in the same limb as well. As far as conformation goes, there are horses that are more predisposed because of their conformation. Stride characteristics to an individual are particular to an individual horse and can actually create more problems with the horse's tendons. Reperfusion injury is something we don't think about with tendinitis, but that would be like your basic bandage bow. So horses that's got a wrap on that's too tight, that can actually result in a reperfusion injury and problems with the tendon. Again, the nature of the working surface, we've addressed that a little bit, but again, it's critical to keep those tendons happy. And we know there are some age-related changes in the tendon that can actually contribute. The next thing I'd like to address would be bone scan. This is something that your veterinary practitioner won't have access to, but certainly is readily available at a referral center, private practice, or university, either way. What happens is a radioactive material is actually injected into the horse. It's a very short-acting radioactive material. And then that's imaged with a gamma camera, and it picks up where the radiation is concentrating, and it concentrates in areas where there's increased blood flow, and that area would be generally the source of the lameness. And you can actually look at both soft tissue with this and also bone metabolism. So just to show you, this is a normal foot right here, and this is a foot that's had bone scan, and this is normal for that horse. And just like thermography, we do compare right side to left side. So here's the normal foot, and I think you see the hot spot on this, indicating there's a problem in this horse's coffin bone or third phalanx. Bone scan is particularly good for horses that have very difficult lamenesses to diagnose, very subtle lamenesses, intermittent lamenesses, multiple limbs can be involved that make it harder to perform the lameness exam, or if there are so many areas that it becomes a bit of a frustration for the veterinarian to perform the standard nerve block. Generally, bone scan is recommended ahead of anything else you might do. You might go back and confirm with nerve blocks at that point for some simple areas. Certainly in a horse that has a very difficult time with needles, it would be preferred to the standard lameness examination with nerve blocks and joint blocks. It's good for early detection of skeletal injury, like fractures before they become complete fractures. And occasionally we use it for just poor performance in general, looking for a place that the horse might be sore, that might be difficult to diagnose. And certainly those horses that have thoracolumbar pain or back pain or pelvic region pain, again, they're more difficult to diagnose. We can't reach them with nerve blocks particularly. And those horses would be a good candidate for bone scan. Didn't want to move along to MRI. This is going to be the state of the art currently for horses, and this is actually one of the more state of the art MRIs. And this is a brand new MRI that we've just gotten at Michigan State University, and it can actually do a fabulous job imaging things that we've never been able to image before. So MRI, or magnetic resonance imaging, just like you would have if you were injured, it's a standard thing that you would get, say, for a cruciate tear. The MRI does provide the ability to see bone pathology and soft tissue structures at the same time. It is the state of the art for imaging both bone and soft tissues, and occasionally the ultrasound actually can overinterpret something, and sometimes we come back with the MRI to actually discern what really is the problem. In addition to standard problems you can see in the bone, you can actually even see edema in bone. Anyway, all the soft tissues are well imaged: the deep digital flexor tendon, suspensory ligament, superficial digital flexor tendon, and I think it's particularly good for soft tissues of the foot, where in the past sometimes we diagnosed navicular disease or navicular syndrome in a horse without knowing exactly what was wrong with the horse. It's a difficult area to image with the ultrasound, looking at the soft tissues in the foot, because the hoof can prevent some of that, and the foot has to be beautifully prepared, and even then it's sometimes hard to image with the ultrasound. Certainly the MRI is beautiful in those areas. And then, I did want to mention on this horse, I think you can see here the suspensory ligament has got a problem, but also there's actually a lesion on the bone as well. And so until this all heals, the horse should not be returned to work. Now, I can't leave off navicular disease because we're talking about performance horses. And so, so that's where we're headed next. As far as common causes of lameness in performance horse, I'm actually going to put arthritis here with arthritis of the hock, stifle, fetlock, and coffin joint, probably the most common that I see. Soft tissue disease would be the superficial and deep digital flexor tendonitis with occasional check ligament, either, in most common it's going to be the distal check ligament there. Suspensor ligament desmitis would be also a fairly common cause of lameness in the performance horse. And that brings us to, again, actually one of my favorites, navicular syndrome. My favorites because it is actually sometimes very difficult to discern exactly what's wrong with the horse. The syndrome part of the navicular kind of encompasses many things, and again, that's where this MRI can actually help you out quite a bit. So true navicular disease is the bone is affected. The navicular ligaments can actually be affected. You can have bursitis, and that actually is the area right here. So there's the navicular bone right here. Can you guys see my pointer? I hope somebody would say if you didn't. Anyway, so here's the navicular bone right here. Here's the navicular bursa right here that actually goes between the navicular bone and the deep digital flexor tendon. Here's the coffin bone right here, the short pastern right here. Then all these other soft tissue structures in the foot, digital cushion, going to be in here, the suspensor ligament of the navicular, impart ligament of the navicular, etc. So any of these areas can actually be problems. Occasionally, because of the proximity of the digital flexor tendon to the navicular, this navicular bone can get very roughened. You can actually get adhesions from the deep digital flexor tendon to the navicular bone, and that's something where, unless that's treated, generally with tonoscopy, that horse is not going to get better with any of the traditional treatments. So it can really give us a good idea, give us a what's wrong in the horse's foot with MRI, and then we can focus on the specific treatment. Okay, so traditionally navicular disease has been diagnosed with pain to hoof testers, palmar digital nerve block. Certainly the foot would be cleaned up better before we'd actually put a needle in it, but this area would be numbed. The horse would go sound then. We know that that would be the area of pain. The horse would actually have pain to hoof testers. We generally get 5 views of the 5 views of the navicular bone with radiographs, and then the horses frequently have a positive fetlock flexion as well. So hoof tester exam, response to the palmar digital nerve block or the heel block. These horses generally have a positive fetlock flexion exam, even though the problem's not in the fetlock, and then we do get generally 5 views on x-rays. So I did want to talk about one view in particular of the x-ray, and I think this will hopefully help you get an idea what's happening in these horses and why the treatments that we recommend might be helpful, and probably, excuse me, probably the one that might make the most sense as a result of the radiographs would be the use of children, and I'm going to show you why that actually might make sense to you. Anyway, so here are the bones. This is the short pastern. This is the navicular bone right here. Here's the coffin bone right here. Okay, and so that's what you're seeing here. Here's the short pastern. Here's the navicular bone. I'm going to actually try and outline it. Oops, sorry. Here. And then here's the other surface of the navicular bone, the flexor and articular surface of the navicular bone right here and here. That's all navicular bone. And then here's the coffin joint right here. Okay, and this is a horse that had a normal navicular bone. So here we are looking at normal again. Here's the flexor and articular surfaces right here. Okay, and I think you can see tiny little holes in here like the drawing right next to it. So that would actually be normal for a horse that's actually been in use for any period of time almost. I think you can see in this view, however, here's the cartoon of it. You can see the channels are getting bigger now, and here you are, the channels are quite a bit bigger. And this is a horse that's got increased channels, and this is of concern to us, particularly if the horse has not had that much use, but even for a horse with a lot of use, those are pretty large channels. Okay, so here's the normal again, and then I think you can see this horse's channels have become so big they're really almost cyst-like. So these cyst-like lesions are actually pretty severe, or actually very severe navicular disease. There are other views of the navicular bone that I'd love to go over with you, but we do probably need to be conscious of the time, so I'm going to go ahead and move along. So classically, we treated these horses with shoeing changes, which are good. We've talked about the importance of that, isoxaprine, bute, and coffin joint injections with hyaluronic acid and steroids, or navicular bursal injections with the same drugs. Generally, the clients that I've had have used the Adequan in the muscle or Legend in the vein. Again, anti-inflammatory agents can help. And then as a last resort, we do occasionally cut the nerves or perform a chemical neurectomy on horses with navicular disease if the disease is not so bad that the horse will be in jeopardy of actually fracturing the bone. Now, what's new for treatment of navicular disease, and I'm going to add arthritis and tendon ligament injuries to my group here, because some of these will actually treat more than one disease. The first one I'm going to talk about is IRAP. Stem cells have got a lot of press lately too. Platelet-rich plasma is a newer drug, newer component of our treatment regimen. Children is actually something that is been on the market in other countries. We do legally get it in the United States now, but it does have to be imported specifically for a horse. Rehabilitation and physical therapy are important. And again, Norell's going to speak about that next time. I did want to mention a few things about some of the oldies and goodies that we've used for treatments long term, and I'm going to talk to you a little bit about butanamine, cosequin, a little bit more about adequan and hyaluronic acid, and then shockwave if we have time. So IRAP therapy has actually had a fabulous impact, I think, in the lameness world in the last several years. It was originally used in humans. In the United States, actually just used in the horse. And what IRAP is it is a protein that actually interferes with a bad protein that the horses make. And so IL-1, which is interleukin-1, is a bad substance that is made in horses when they have joint disease, and it's an important mediator of arthritis. So we want to actually get rid of this IL-1. And so what IRAP is this IL-1 or interleukin-1 receptor antagonist protein. It actually nullifies the effect of IL-1. So it's the good treatment of a bad mediator of arthritis. And with IRAP, I think you can see that these anti-inflammatory agents that are concentrated in the IRAP, they're concentrated several fold. And so what we want to do is we want to use the anti-inflammatory agents in IRAP, and we don't want to change the ones that are pro-inflammatory, ones that create inflammation. And I think you can see here that they've adjusted the formulation of the bead so that the things that are pro-inflammatory or cause problems are actually not increased. And so what does this mean to you and your horse? Well, we actually take blood from the horse's jugular vein into a special syringe. And I think you can see in this syringe there are glass beads. Actually, you can see little beads in here. And those beads are actually specific so that they can actually concentrate, they stimulate the white blood cells to produce and concentrate the anti-inflammatory and regenerative cytokines, the substances secreted by the cells that will actually inhibit the arthritis. So the blood is incubated overnight in this tube with these beads, and then it's centrifuged and collected into a specialized syringe that you will then inject into the horse. It is filtered and is done completely sterilely. In fact, generally when I do this, I actually wear gloves, both hands, and this is a sterile surgical prep on the horse's neck so that we don't have the opportunity to introduce infection into the horse's joint this way. And it does work very well, and it's worked well in a variety of joints, coffin joints, stifles, fetlocks, actually quite a few joints, and people are injecting it in other things as well, like the navicular bursa, etc. So IRAP is actually something that's very easy to use and is standard sort of injection, and comes from the horse themselves, and so it's not necessarily introducing a drug into the horse. So people like it for that reason as well. Stem cells has got a lot of press lately for a lot of reasons, actually. You read Time magazine about stem cells even. But there are two basic types that we use in horses. One would be a fat-derived stem cell, where you actually take the fat out of the horse and then grow the stem cells, harvest the stem cells and then inject them back into the horse. Or this bone marrow-derived stem cell, where your veterinarian will actually take bone marrow usually from the horse's sternum, and harvest that and then inject it back into the area that requires the treatment. Both work well. The fat-derived stem cells have to be sent off, and your veterinarian can generally do the bone marrow-derived stem cells in their practice. The performance horse veterinarians can. It does deliver active fibroblasts to the area that's a problem. So if you've got a tendonitis, a hole in the tendon, suspensory desmitis, any of those, you should see an improved healing and fiber pattern. Again, you will get these horses back also in light work like walking at the same time, so that the fiber alignment is actually good, so the horse actually has long-term recovery. We do know that horses involved in jumping, barrel racing, and other, at least the non-race disciplines, have returned to performance at their pre-injury level. I think the work on the race horses is actually coming out, or maybe has recently come out. Did want to actually talk a little bit about this. I know we're starting to run out of time. Oops. And this is the slide that I've lost my title on, but this is platelet-rich plasma. And this is basically harvesting the horse's own blood in specific bags and then actually getting these platelets out. And these are what platelets look like on electron microscopy. And these platelets actually have factors that are important for the growth of tissues in them. And so this platelet-rich plasma is then injected back in the horse, similar to what the IRAP is, and it's been used for the treatment of several joint disorders, tendons, etc. And actually, people are injecting joints as well. It's a little bit newer, and not as much work has yet been done on it, but it is an up-and-coming sort of drug, it appears. As far as children goes, that is something we talked about when we showed you the slides of the horses with navicular disease. You did see those areas were starting to, the bone of the navicular bone was starting to be reabsorbed. And what children does is it actually decreases the function of the cells that eat that bone. So much like, in fact, this is a type of drug that is used in women that have osteoporosis to wipe out the cells or alter the cells that actually chew up the bone. It does actually do the same thing in the horse. It does alter the cell function so the bone is not getting chewed up, and it changes the remodeling of stresses on the horse's bone in that fashion. There is some good evidence with the children for horses with navicular disease, with back pain, and with some hock arthritis. There are some new bisphosphonates that are soon to be coming on the market, apparently, that may actually even one-up the children. Again, I'm not going to speak about rehabilitation and physical therapy, but Norel we'll be speaking about it for an entire lecture. It is a critical step in the return to athletic performance of all of these horses. Again, we're at the tail end of the lecture. I did want to say a few things before I let you go, though, about drugs that you commonly give or are very familiar with. My first one is butte and banamine, or phenylbutazone and banamine. Neither of these drugs really should really be given in the muscle. This is actually a sloughing of part of this horse's neck from banamine. I've actually seen much worse sloughs of the neck or injection sites where banamine has been given in the muscle. I know it's commonly done. Every now and then your horse will get very unlucky, and then occasionally I have a horse that sloughs so much that it, from then on out, has difficulty with flexion of the neck. And as you know, performance horses that can't flex their neck are not performing at the same level as the ones that can. The banamine that you get, that you can actually have been injecting the neck, you can actually stick that right in the horse's mouth, right out of the bottle. You can mix it with molasses, stick it in the horse's mouth at instructions of your veterinarian, but it works very well. That same drug you have in the bottle for IV works very well orally. Again, IV is no problem. Orally is no problem. It's just the ones that are given in the neck that can occasionally become a bad problem for your horse. The other thing I wanted to say about butte and banamine, and put ketofin in that group as well, another non-steroidal, is that they really should be given separately. And you'll know you probably are aware of a new FEI ruling on the use of more than one non-steroidal drug, as they're called, at the time. You actually don't gain enough to make it worthwhile when you give both banamine and butte to the horse at the same time. If the horse needs both drugs to be sound, then that's a horse that probably should not be working, number one. And two, it's double the toxicity, or even perhaps more. So banamine and butte both can cause ulcers of the horse's mouth, esophagus, and stomach, and right dorsal colon, and they can also cause kidney disease in horses. In fact, they can cause kidney failure if given enough doses. And so if you don't get an adequate response to one dose of banamine, which is going to be about 500 milligrams in a normal horse, or 1.5 to 2 grams of butte in a normal horse, it's not advisable to actually double that up with either another dose of banamine or another dose of butte. Don't exceed the recommended dose, and don't double up one drug to the other. Did want to say a little something about chondroitin sulfates and glucosamine. They are very safe in horses. It's something that's fed to the horse on a daily basis. Human athletes take it, horses take it. They have preparations for dogs and cats now, I think, even as well. The combination does serve to protect cartilage. This is an older bottle of Cosequent here. They actually have ASU in it, saponified avocado and soy, and that actually probably is even a little bit better, or actually even better anti-inflammatory. But I did want to make a point saying that these chondroitin sulfate and glucosamine products are not created equally. There have been 2 studies so far. One of them, the first one, I believe 2 out of the 10 drugs tested actually had what they said they had in them. In the last study, and this is it, 14 out of the 23 products that were actually sold as chondroitin and glucosamine, 14 out of the 23 were actually adequate. So actually had what they said they had in it. So stick with a name that you can trust for these drugs. Otherwise, you're probably throwing your money away and potentially giving your horse something even possibly deleterious. So again, pick a brand that is a good brand. Again, want to say a little bit about Adequan and hyaluronic acid and corticosteroids. These are probably the mainstay of anti-arthritis medications. These can actually be given in the joint, okay, and they can also be given in the horse. And I'm going to talk a little bit about steroids. We generally don't give these, we shouldn't administer these to horse before performance for a couple of reasons. And actually, it's best to actually administer all of these drugs sometime, some number of days to even weeks before the horse actually performs. So the things I wanted to mention about Adequan, it is a potent enzyme inhibitor, and that's why it works so well in these horses that it does work in. Frequently, I have clients that give the drug once a month, which is good. If you're actually having a flare-up of the horse's lameness, it is 1 shot every 4 days for 7 treatments. And so if the horse is actually maintained on Adequan at a once a month, that's fine. But if the horse has got an exacerbation of lameness, you may need to go back to that 1 shot every 4 days. And you'll get a lot more bang for your buck that way. Certainly it's a lot more buck though too. It does stimulate hyaluronic acid production, proteoglycan synthesis, collagen synthesis. I have here that it can be used in the vein. That's not right. It can be used in the muscle and in the joint. I apologize for that. It can be used in the muscle, not the vein, and in the joint. Sodium hyaluronate. Okay, so this is your Legends, your Hylartins, your Hyavisc. They're used in horses and in humans. They do reduce pain and increase mobility in horses and humans with joint disease. They do compare favorably with the butes and the banamines and the steroids. They're anti-inflammatories. They can provide soft tissue lubrication. We do use these drugs in the horse in the vein, and that would be your Legend in the vein, and then also directly in the joint. Now, I do want to mention that not all sodium hyaluronic products are created equally. Legend is the one that's licensed for use in the vein. When you get down to the point where we're actually going to be using drugs in the horse's joints, though, for joint injection, say you've specified that the horse maybe has a fetlock lameness and you want to inject the fetlock joint, or your vet's going to inject the fetlock joint, don't ask for the cheapest drug to be injected, ask for the best drug. And this is kind of something that's worthwhile looking at. Here's Legend, very good in the vein, okay, and not that expensive. But as you go up the list here, these higher molecular weight drugs actually work better. And so if you're going to go to the trouble to actually stick it in the horse's joint, okay, again, ask for the best one, not the least expensive one for the joint. It'll actually pay in the long run for you and your horse. Whenever possible, I would say buy the best drugs you can buy for your horse. And I do want to address that at the very end as well. Now, I see this a lot. Corticosteroids are still controversial in the use, at least the way they're used in horses right now. We do see horses that get frequently injected with steroids because the horse owner believes, or the trainer believes, the horse might need it. If you really look at elite athletes across species, we don't do this in anything but the horse that I can think of. We don't do it in dogs that are elite athletes. We certainly don't do it in humans. You know, if you thought about one of your favorite, say, Olympic athletes, say Apollo Ono comes to mind, if you asked him, gee, would you like some steroid in any of your joints before you race in the Olympics, I'm sure he would say no. Any injection will actually alter the feeling for that joint, alter the proprioception for that joint. So it can actually make the horse's foot flight altered immediately after injection. If you are going to use these drugs, we try and get them away from the time the horse is going to be exercised at first, and preferably only in joints that actually need it. So they do have some negative effects also with steroids, particularly at higher doses. It will actually decrease chondrocyte metabolism or negatively inhibit chondrocyte metabolism, and cause some disorganization of the collagen fibers, and that actually is long-term, it's going to be a long-term problem for the horse if that continues to be used in that fashion. And this is usually at high concentrations. At low concentrations, they actually tend to be pretty good in joints, and actually sometimes very, very good in joints. They do inhibit potently those enzymes that we talked about before, and the cytokines. Again, generally best in low concentrations in joints that actually need it, not just as preventative. The last thing I want to talk about would be compounded drugs, and I did want to remind you about the 21 polo ponies that died in 2009. Those drugs were compounded. Okay, so compounded drugs are drugs that are compounded by a compounding pharmacist. You might have heard of generic drugs. Okay, those are actually FDA-approved drugs. The standard drug, again, FDA approved. Compounded drugs are the drugs that are compounded by specialty pharmacists, compounding pharmacists, and they have not particularly had the scrutiny in the past that perhaps they should have. I know the American Association of Equine Practitioners actually has rules governing the use of compounded drugs. And again, the reason that those 21 polo ponies died was because they got an inappropriate compounded drug. So again, just another reminder to use the best drug you can possibly afford. And that's the end of my presentation for today. I believe that I am supposed to now answer any questions that have not been addressed. And I do appreciate Narelle Stubbs. She's been wonderful for answering questions as I've been talking along, and I do appreciate it. I see a note from Jody here about her vet prescribing acetyl D-glucosamine for the barrel horse. It's actually sort of a generic form of something more like Adequan, or kind of mixed between Conjoints and Adequan. It is a compounded drug, though. It is, as far as my knowledge, is only available from compounding agencies, and so it'd be one where if the horse responded to that, perhaps Adequan would be a better choice. I see also Peggy says she had a severe navicular disease horse that is now quite useful using natural balance shoeing. Certainly, the better job on the horse's feet, the more likely the horse is to be comfortable. I do appreciate you actually mentioning that. Thank you, Peggy. Okay, so let's see here. I have are oral HA supplements effective? as a question from Lori. It's interesting. The jury, I think, is still out on the HA supplements. If I were going to spend my money on a supplement, I would actually use the chondroitin glucosamine combination like Cosequin. Let's see, what else have I got here? Stephanie has a compounded drug question. Her 32-year-old horse has Cushing syndrome that takes Pergolide capsule daily. Unfortunately, right now, that is the only way you can actually purchase Pergolide is by compounding. I believe Boehringer Ingelheim should have a new product on the market, which is a FDA-approved Pergolide shortly. I know that it is actually on the market in Europe, and it is, I think it's in clinical trials right now and it's soon to be released. That study actually was partly done here, and Dr. Hal Schott would be better able to tell you when that drug is going to be out. But yes, right now that is the only way you can actually get Pergolide. So yes, I would continue with it. Barb asks about shockwave therapy that was used on our 23-year-old distance horse. He rode 800 miles last year. Gotta love that, Barb. Good job. And she don't say what you actually shockwave the horse for, but it can actually improve fiber alignment in tendons and ligaments, and people have used it for a variety of things as well. It's a human also treatment. So I'm glad that it worked for your horse. There's a question from Janet about natural herbal applications as anti-inflammatory aids. It's interesting. Some of the natural herbals actually have a fair amount of aspirin in them, and so I'm just wondering how. It would depend specifically on the herbal medication. Certainly, some of them are better than others, and would have to know a little bit more about your specific herbal. Personally, I would use the drugs that are FDA approved as a first choice, however, above the herbals. Do I recommend giving, Jody asked if I recommend giving joint supplement to horses. If I were going to give one, I'd give one that would treat the whole horse. And so, again, I'd go back to something oral, like the glucosamine chondroitins or an Adequan shot as preventive once a month sort of thing. I think those are reasonable things. Horses aren't lame, but to actually keep them going, yes, I think those are very reasonable, and I'd certainly rather do that than inject the horse's joints with corticosteroids or whatever. And there's a very nice study with Adequan in particular, I believe, where the intramuscular Adequan actually decreased the need for the intra-articular medications in a fairly large group of horses. And so I would use either Adequan or Legend, depending which works better for you in those horses. What do I think about chiropractor, acupuncture, and chiropractic on soreness? I actually don't do acupuncture, but I would, if I had a horse that needed, I would actually not hesitate to get the horse acupunctured. I would actually go to my preference would be somebody who was very well acquainted with acupuncture and very good at it. Same thing as chiropractic. Big span of abilities in both those fields. Certainly the veterinarians that have undergone the acupuncture courses would be good choices. The people that have actually gone to the 4-year programs for acupuncture, very good. I have a very good friend that Lydia Wainwright that has done a lot of acupuncture in horses and had worked with her on some of those, and they seem to do very well. So yes, I think acupuncture is good. Chiropractic, boy, big span there. Kevin Hauser is the genius on chiropractic, and I would definitely have him treat my horse any day. And then I've had chiropractors that weren't nearly as qualified or as good, and we know that horses don't actually put ribs out, just like humans don't actually get ribs out. It's something a little bit different. We just use the wrong terminology for it. But there are things you can do for the horse, and I believe Norel will be addressing those as well. But there are things you can do for the horse to manipulate them, to make them more comfortable, to increase their flexibility and things like that. And certainly if that is what your chiropractor is doing, I definitely would agree with that. again, I do want to say thank you again to Narelle Stubbs, who's been just wonderful answering questions. And actually, I made her look at some of my videos ahead of time, and I do appreciate that. And all the contributors to the notes, Dr. Bob Linford for the video, Dr. Hillary Clayton for the beautiful video and photos, our group here in radiology for the MRI. It's wonderful, and we're very pleased to have that new MRI. It's been fabulous. Tia Failing for the Farriery, Jim Wald-Smith for the Thermography.
Okay, well, if we're going to go ahead and conclude, I just want to say a couple of thank yous as well, especially to Dr. Rashmir for her presentation, and again to Narelle for answering our questions tonight, and especially to all of you for participating. And later this week, you will receive an invitation to participate in an online survey, and if you would take a few minutes to give us your feedback, that will really help us.
We would really appreciate you giving the feedback for that survey. Thank you so much.
Yeah, and also want to let you know that, again, next week, our questions facilitator from tonight, Narelle Stubbs, will be giving a free webcast on rehabilitating the lame horse. And then next month, we will finish our horse health series with an equine emergency first aid free webcast. And want to remind you that My Horse University is now on Facebook, so please become our fan and have access to exclusive deals and get the most up-to-date information on our events, courses, and more. And again, tonight's webcast was recorded and will be uploaded to our website by the end of the week. And you can send us your comments and suggestions to info@myhorseuniversity.com. And thanks again, and have a great evening.
Thank you, Amanda.